Okay, so we're going to talk about diseases of the anterior pituitary here. And the anterior pituitary secretes the hormones FSH, LH, ACTH, TSH, prolactin, and GH. Now, the big difference between the anterior pituitary and the posterior pituitary, besides the fact that they secrete different hormones, is that the anterior pituitary, the adenohypophysis, creates the hormones that it secretes, whereas the posterior pituitary is more of just a conduit. The hypothalamus actually makes the hormones it secretes, and it just goes through the posterior pituitary. So the anterior pituitary is stimulated to release the hormones that it has by the hypothalamus, and the hypothalamus secretes certain releasing hormones which correspond to each of the anterior pituitary hormones. So for FSH and LH, it's gonadotropin releasing hormone. For ACTH, it's corticotropin releasing hormone. For TSH, it's thyrotropin releasing hormone. For prolactin, it's actually an inhibitory effect. It's dopamine working against the secretion. And then for GH, it's growth hormone releasing hormone. So there's a full review on, I did a physiology review. You should be able to find that pretty easily. Okay, so flat pig is the mnemonic, and I stands for nothing, but you can see here that if you line them up, they spell flat pig. Or flat peg, if you want to put an E there, or whatever. Alright, so here's some anatomy. So the posterior pituitary is here in the brown, and it's connected to the anterior pituitary, but remember that they are they're different tissue. The anterior pituitary is separated into three different parts. The pars tuberalis, which is the part that connects it up to the hypothalamus. The pars distalis, which is the main body of the anterior pituitary, which holds the hormones that it secretes, and then the pars intermedia, which is important because it releases melanocyte stimulating hormone, which is stimulated to be released by corticotropin releasing hormone, which also stimulates the release of ACTH. And the anterior pituitary sits in the hypophyseal fossa, which is in the just above the sella turcica. And the sella turcica is part of the sphenoid bone, and it's just this indentation, and this holds this little cavity that protects the pituitary. So this is looking upwards from an inferior view, and the pituitary here is dissected, so we see the stalk, which goes up to the hypothalamus, and then we also see the optic chiasm here. Now, the reason that I show you this is because if you get an adenoma on your pituitary, so like a tumor, you can get compression of the optic chiasm, and that's going to cause visual deficits, and we see that in certain disorders. So this is an MRI, and it's no contrast. So we see pituitary is right here, and it's sitting inside the so the sella turcica would be right here, and then here is a sinus, the cavernous sinus. Okay, so the diseases of the anterior pituitary. We're going to talk about two of them that come from functioning adenomas. The most common functioning adenomas, which would be a prolactin-secreting adenoma and a growth hormone-secreting adenoma. And those would be hyperprolactinemia and acromegaly. There's also non-functioning adenomas, which would be a cause of hypopituitarism. The main causes of hypopituitarism that we're going to talk about are pituitary apoplexy and Sheehan syndrome. The other causes of hypopituitarism that aren't going to be discussed are stroke, infiltration, autoimmune disease, and trauma. And then we'll briefly talk about empty Sella syndrome. Okay, hypoprolactinemia. So what are the causes of hyperprolactinemia? So hyperprolactinemia is just an increased amount of prolactin in the bloodstream, which causes certain symptoms that we'll talk about in a little bit. But the causes for hyperprolactinemia most prominently are an adenoma. So an adenoma is a tumor that is creating prolactin. And then there are various drugs. So SSRIs, antipsychotics, because of their inhibitory effect, and then alpha-methyl-dopa and cocaine. Hypothyroidism and mass effect can also cause the secretion of prolactin. So for hypothyroidism, I did that's part of the review, the physiology review, as well as the various drugs. So the adenoma, basically, what causes the adenoma to release prolactin is just the adenoma itself. So that's pretty simple. You just have a tumor secreting prolactin, and that's why you have hyperprolactinemia. And what happens is with an adenoma, one of the distinguishing effects that separate it from the other causes of hyperprolactinemia is the fact that you have an adenoma compressing the optic chiasm, and that can cause visual deficits, and that's bitemporal hemianopsia. And when you have compression at the optic chiasm, it causes a visual field deficit on the lateral sides of the visual field. Damage to the pituitary stalk from the hypothalamus can also cause hyperprolactinemia, and the reason for that is because you get a decreased amount of dopamine to the anterior pituitary. And remember, part of the prolactin axis is that dopamine inhibits the release of prolactin. So if you have anything that inhibits dopamine, be it an antipsychotic or be it damage to the pituitary stalk, which causes a lack of dopamine to be delivered to the anterior pituitary, that's going to increase the release of prolactin. So damage to the pituitary stalk causes increase in prolactin. And in drugs, antidepressants increase the amount of serotonin, and anything that increases the amount of serotonin can increase prolactin. And the reason for that is because serotonin is a prolactin releasing factor. Antipsychotics cause an increase in prolactin because they act to inhibit dopamine. So if you have a dopamine inhibitor in the bloodstream, then you're going to increase prolactin. Prolactin is regulated by the prolactin releasing factors, which are most notably serotonin and thyrotropin releasing hormone, and a negative effect by dopamine. So anything that inhibits dopamine or increases TRH or serotonin is going to increase prolactin. And then alpha-methyl-dopa and cocaine are other drugs that can cause an increase in prolactin. As far as hypothyroidism, so remember that I said TRH is a prolactin releasing factor. Well, how do we get a high TRH? The same reason we get a high TSH, and that can be hypothyroidism. So let's say your thyroid is diseased. Let's say you have Hashimoto thyroiditis, or you had a thyroidectomy. Now you're not getting your T3 and T4. So you have a low amount of T3 and T4. Because T3 and T4 is inhibitory, it causes negative feedback to the anterior pituitary and to the hypothalamus. Now you're going to get stimulation of you're taking your foot off the brake. You're getting no negative feedback to your hypothalamus and your anterior pituitary. And so since you're not getting any negative feedback to your hypothalamus, your TRH levels are going to be very, very high. And TRH acts as a stimulator to release prolactin. And so hypothyroidism can cause prolactin release. Hopefully I explained that well enough. I never think I explain things well enough. Okay, so primarily here we're going to talk about hyperprolactinemia as an effect of adenoma. So generally with when it's hypothyroidism or trauma or various drugs, it should be pretty clear. Either the various drugs are in the patient's history. The hypothyroidism, you'll have other symptoms related to the hypothyroidism. or with mass effect or trauma, that'll also be in the patient's history. I will say, anytime you have symptoms of hyperprolactinemia, you should always get a TSH, because if the TSH is elevated, you should think of hypothyroidism as a cause. But we're going to talk about adenomas as a cause of hyperprolactinemia from here on out. So in women, when you have an adenoma, a prolactinoma, which is an adenoma that secretes prolactin, it tends to be a microadenoma. And in men, it tends to be a macroadenoma. So you might say, well, then how do we know when it's present in women? Well, prolactin blocks the effect of the gonadotropes. And when you have a blocked LH and FSH, what happens in women is that it's going to interfere with the menstrual cycle. So when LH and FSH can't work, you don't get ovulation, and then you have no period. So amenorrhea is a symptom of hyperprolactinemia in women. Galactorrhea is another symptom because prolactin is going to cause the creation of milk. Now in men, obviously they don't menstruate and they don't have enough tissue to create enough milk to be expelled. So amenorrhea and galactorrhea will not be the symptoms. But thankfully, in men, it's a macroadenoma. And why I say thankfully is because one of the symptoms that helps us distinguish it in men is the bitemporal hemianopsia. And so because it's that big macroadenoma, it's going to impinge on the optic chiasm, and that's going to cause the lateral field deficits. Now, high prolactin levels can cause gynecomastia in men. So even though you're not getting milk from the prolactin, you are getting stimulated tissue, and so you can get gynecomastia. And prolactin, because it blocks LH and FSH, right? Yeah, men aren't having periods, of course, but LH and FSH stimulate the testes to create testosterone. And because LH and FSH are inhibited by prolactin, because you're not going to get testosterone release in men. So you're going to have a decreased testosterone, and that can cause decreased libido and erectile dysfunction. So gynecomastia, decreased libido, erectile dysfunction, and most importantly, bitemporal hemianopsia are the symptoms we would see in men. And so this is just sort of going over those effects. So prolactin has a negative effect on GnRH and LH and FSH, and that causes amenorrhea. And prolactin itself causes galactorrhea and gynecomastia. In men, it causes erectile dysfunction and decreased libido. Okay, so the best initial test, and also in both, symptoms consistent with hypothyroidism may be present if it's actually due to hypothyroidism. So that's why I put that there. Okay, so the diagnosis for hyperprolactinemia. If you have a patient that you think, I think this patient has high prolactin levels because she's not getting her period and she's secreting milk from her breasts, or he's got bitemporal hemianopsia and gynecomastia, the best initial test is going to be a prolactin level. If the prolactin level is high, then you should go ahead and get the MRI. That's the most accurate test. So a high prolactin level does not necessarily mean that it's an adenoma. So we have to get the MRI to know that it's an adenoma. You should also, as I mentioned, get a TSH on any patient with a high prolactin level, because hypothyroidism is a cause of hyperprolactinemia. If we diagnose if it's a prolactinoma, if we diagnose it as a prolactinoma, then the best therapy is going to be a dopamine agonist. And what that allows is for dopamine to have that inhibitory effect on prolactin. And so cabergoline and bromocriptine are valid treatments. So this is a prolactinoma here, and you can see that you have a much smaller sinus here because you have a much larger anterior pituitary. It's kind of hard to make it out here, but it is enlarged. You can't really see the tumor separate from the anterior pituitary, but that's why we have radiologists. I can't imagine you'd get a question like this on the test. I mean, you will get a question on a prolactinoma, but I don't think they're ever going to ask you to diagnose it radiologically. Okay, so acromegaly. So acromegaly is an adenoma, generally a macroadenoma, that secretes growth hormone. And this will typically present in patients in their 20s to 40s, both men and women equally. The symptoms from increased growth hormone are skeletal changes, coarsening of facial features, enlargement of hands and feet, deepening of the voice, carpal tunnel syndrome, and congestive heart failure. And I sort of tried to put those in the sequence in how they tend to be noticed. Now, what I will say is acromegaly is only occurs in adults, so it's got to be a growth hormone tumor that occurs in an adult where the epiphyseal plates are closed. You're going to get much different symptoms than if you got a growth hormone adenoma in a child. You'd get gigantism, where the kid would grow up to be 7.5, 8 feet tall. And that's because their growth plates aren't done closing, and so their bones will continue to enlarge. So acromegaly is in adults, whereas gigantism is something that happens in kids, and that's a different disease. So here is a few patients with acromegaly. So what I want to point out here is the facial features. So you've got a protrusion of the jaw. That's very common. An enlarged tongue. And then because the jaw protrudes and the mandible is enlarged, what happens is you get the separation of the teeth. And so that's another symptom. And you see it here in this patient too. This is in a woman. So obviously she gained a bunch of weight. I don't know if weight gain is necessarily a symptom, but it can be a comorbidity. So here's the hands. You get enlargement of hands and feet. And so this is another cause where the ring will stop fitting the man or the woman affected. So their wedding ring may not fit anymore. What's another thing we might see that in? Psoriatic arthritis. Here's an x-ray. Okay, so the best initial test when we suspect acromegaly, and usually it's going to be very clear based on the skeletal changes and the coarsening of the facial features, deepening of the voice in women. The best initial test is going to be an IGF-1 level. That's an easy test, and that can be gathered pretty quickly. With the IGF-1 level can be corroborated with an actual direct growth hormone level, and usually what we do is we stimulate the release of growth hormone by giving 100 grams of glucose. So what normally happens is that when we have a low glucose level, then that's going to cause an increased growth hormone. So when we give this glucose, we are going to expect a low growth hormone level. So by giving 100 grams of glucose, if the growth hormone level is still high or normal or high, then we know that there's an exogenous, or not exogenous, but a secretion of growth hormone that's not being regulated. And so that's going to be consistent with an adenoma. And then the most accurate test is going to be an MRI, which is needed for definitive diagnosis. So the best initial and most effective therapy is transsphenoidal resection. So it's actually a surgical procedure where you go up through the mouth and into the through the sella turcica to resect the adenoma. That's the most effective therapy. The best medical therapy is octreotide. There are other drugs that can be given for acromegaly. They include dopamine agonists, so cabergoline and bromocriptine. There's pegvisomant, which is, I believe, an IGF inhibitor, and then radiation therapy. So this is just sort of sums it up. Actually, it's a growth hormone inhibitor. I was wrong. Okay, and octreotide is the best medical therapy, so remember that. That's going to be the question you'll be asked on the USMLE. If you're asked what the best therapy is, it's the transsphenoidal resection. If that fails, then you'll give medical therapy, and it will be octreotide. All right, so hypopituitarism. So this is a decrease in pituitary hormone levels. And all the causes we're going to talk about are going to be pan-hypopituitarism. So across the board, decrease in pituitary hormone levels. So the two specific disease processes that we're going to talk about are pituitary apoplexy and Sheehan syndrome. So pituitary apoplexy is a hemorrhage into the pituitary, and that's usually caused from the existence of an adenoma. Not all the time do we remove an adenoma because that would require surgery. So some patients will have an adenoma. They may know about it, they might not. But if you have an adenoma, you're at risk for hemorrhage. And when you get hemorrhage, it can destroy the pituitary. So what would happen is you would get acute symptoms of headache, nausea, vomiting. You can have altered mental status. And some of the more severe symptoms would be low blood pressure or low blood sugar. And that would be because of a sudden decrease in cortisol levels, because of the decrease in ACTH. Sheehan syndrome is a disease that's specific to pregnancy. So it's ischemic necrosis of the pituitary postpartum, and this can be caused from emboli. It can be caused from severe hypotension during delivery. So it's actually something that we can try and prevent. So usually it's going to be noted by difficulty breastfeeding in a woman after she delivers. It can also be noted in a woman if she's not breastfeeding by extended amenorrhea. So usually a woman should start to have her period again around 3 months after she delivers. If she's gone a year without delivering, then you might think Sheehan syndrome. Now remember, if she's breastfeeding, she's not going to have her period because she's secreting prolactin. And that prolactin is going to block the LH and FSH, and so therefore she's not going to have her period. So make sure you ask if she's breastfeeding. So difficulty breastfeeding can be a sign of Sheehan syndrome. Another sign could be just hypotension in general, and that's again because of a low ACTH, a low cortisol level. Another cause of Sheehan syndrome that's good to remember is HELP syndrome. So the high liver enzymes, low platelets. Infiltration is another cause of hypopituitarism, but again, the ones from here on down are just sort of more secondary hypopituitarism, whereas these are specific diseases. A non-functioning adenoma, I suppose, would be a primary cause of hypopituitarism. So that's another thing you should consider when a patient has signs of decreased levels of pituitary hormones. So how do we diagnose hypopituitarism? Okay, what are the symptoms? Usually, when a patient has any kind of disease process that's killing off the pituitary, it's going to be the LH and FSH levels that are affected first, then it'll be the growth hormone levels, then it'll be the thyroid hormone levels, then it will be the ACTH. And these are kind of in order of severity. So a decreased LH and FSH, as we already talked about, can be amenorrhea, infertility, decreased pubic and axillary hair, genital atrophy, decreased libido, and erectile dysfunction. Decreased growth hormone, generally that's going to be clinically undetectable in an adult. It could manifest as increased lipid levels, but usually you're not going to detect it. In children, you would be able to detect it. Decreased TSH manifests as just basic hypothyroidism, so fatigue, weight gain, weakness, decreased appetite, and cold intolerance. And then decreased ACTH would be fatigue, decreased appetite, decreased pigmentation, because you're getting increased CRH stimulation, so you're going to get MSH being released from the pars intermedia. That still works. And then low blood pressure and low glucose. So the best initial test is going to be to measure the levels of the anterior pituitary hormones. So anytime we think hypopituitarism, the best first test to do is to measure your hormone levels. So measure all of these. So how do we measure these? There are different tests. For LH and FSH, we just do direct measurements. For growth hormone, we can either indirectly measure it with IGF-1 or directly measure it with growth hormone with an insulin response test. So remember how we talked about how we diagnose acromegaly. We can get an IGF-1 level, or then we can do a growth hormone level. But remember, that growth hormone level was in response to glucose. Why? Because glucose will inhibit the release of growth hormone. And in acromegaly, we have an adenoma. And if you have an adenoma, then you're not going to have any inhibitory success. So you have an adenoma that's just ectopically secreting growth hormone. So the glucose was done to see if we have ectopic production. Now, in this case, we have low growth hormone, and we want to see if we have a low growth hormone level due to panhypopituitarism. So what we're going to do in this case is just the reverse. We're going to try to get the pituitary to secrete growth hormone rather than try to inhibit it from secreting growth hormones. We're doing the exact opposite. We're going to administer insulin to try to get it to not secrete, to try to get it to secrete growth hormone level. So just the opposite as the test that we did in acromegaly. So what we do is we administer 0.1 micrograms per kilogram of insulin, or we just titrate it until the blood glucose level is 40 milligrams per deciliter. And what should happen is that the low glucose should stimulate the release of growth hormone. If we're not getting a stimulation of growth hormone release, if the growth hormone is low, if it's less than 10 milligrams per liter, then we know that we've got hypopituitarism as far as growth hormone is concerned, because we're not able to get growth hormone release. So this is the exact opposite of the test that we do to measure growth hormone in acromegaly. They're similar mechanisms, but just the exact opposite. We use insulin here rather than a glucose administration. For TSH, it's pretty easy. We just measure it directly by measuring TSH, T3, and T4. And then ACTH, we measure it indirectly via cortisol. So we talked about the symptoms. As far as diagnosis, the best initial test is to measure the levels of anterior pituitary hormones, but in order to make a definitive diagnosis, we have to do an MRI, and either that would be to confirm pituitary apoplexy, which should show up on the MRI, or we would do it to exclude adenoma. So even in a woman where we're suspecting Sheehan syndrome, we should get an MRI to exclude adenoma. Generally, we're going to know that the most likely diagnosis is Sheehan syndrome, but we get the MRI to exclude adenoma. So always get an MRI in any patient with hypopituitarism to exclude adenoma, but MRI is diagnostic for pituitary apoplexy. How do we treat this? We treat the underlying cause and we give hormone replacement. So we would be giving thyroid hormone, we would be giving hydrocortisone or prednisone, we would be giving estrogens or progesterones or testosterones. We're just replacing the hormones to manage it symptomatically. Occasionally, we need to treat the underlying cause, and that's for the emergent cause, which would be pituitary apoplexy. And in that case, surgical decompression is going to be needed. So for pituitary apoplexy, we're going to need surgical management. Okay, finally, we're going to talk about empty Sella syndrome. So empty Sella syndrome is an easy one because you don't have to treat it, and it's not really important. It's generally just an incidental finding. Usually it doesn't cause any significant decrease in pituitary hormone levels, but it is a disease of the pituitary, so we're including it here. And it does come up on the USMLE. So generally this is just an incidental finding if we're getting an MRI for a different reason. But if it presents, it will present usually as a benign intracranial hypertension. Generally, it's usually a feature of benign intracranial hypertension. So the woman would, or the man or woman would present with other symptoms that are related to the benign intracranial hypertension, and the benign intracranial hypertension will cause empty Sella syndrome. No therapy is needed for this. So what you might get on the USMLE is an image. So note here, I put two of these up here. Why did I put two of these up here? Because one has contrast and one doesn't. So here we don't have any contrast. So what does contrast do? It just illuminates your ventricles, and it basically illuminates everything where there's CSF. So here we don't have contrast, so we would expect the pituitary to look like brain, not to look like ventricle. And look at that here. It looks like ventricle, and the reason is because your arachnoid mater has herniated into where the pituitary is. So in this case here, where we do have contrast, we see that it's, again, the same color as ventricle. That should not happen. It should be the same color as brain tissue, and it's not. And going back to the normal brain, where we don't have empty Sella syndrome, here you've got your pituitary, and it's the same color as brain, not the same color as ventricle. So this is no contrast here. And that's it.